Dr. McClelland, I'm going to ask you a little about hepatitis now. I'm going to start with an article at WITN 3082021. This is an article in the Ulster Medical Journal, Hepatitis B virus infection in Northern Ireland, 1970 to 1987, and we can see that you are a co-author of this article. And then, if we just look at the summary, in the 18 years between 1970 and 1987, 504 patients were found to have hepatitis B surface antigen in their blood. Acute hepatitis was present in 184 patients and 6 died. The annual incidence of acute hepatitis B virus infection in Northern Ireland was about 1/4 that of England and Wales. A decrease in acute infection occurred in 86 to 87, while in England and Wales acute infection has fallen by more than half since the peak in 1984. Hepatitis B virus infection in healthcare staff and patients in high-risk groups were reviewed. 32% were in those of foreign origin or who had known foreign contacts. In blood donors, there was a marked fall in incidence of hepatitis B surface antigen carriage from 1982 onwards. Now, I'll come back to that 1982 date in a moment, but if we can go over the page. And look at the third paragraph. This gives us the dates of the various tests that were in use in the transfusion service. The Northern Ireland Blood Transfusion Service began routine screening of all blood donors in 1972 using the immunoelectro-osmophoresis test. The RPHA test was introduced in 1975 and the radioimmunoassay test, BPL-Elstree, in 1982. ELISA test used since July 1987. And then we can see, if we then go over the page to go to page 4, please. Halfway down the page, there's a heading, Blood and Blood Products Transmission. And then we have the subheading Haemophiliacs. Acute infections occurred in 11 patients between 1972 and 1982 after receiving blood transfusions, cryoprecipitate or factor VIII, and 1 patient died aged 51 years. And then the next paragraph, multiple transfusions. Acute infections took place between 1970 and 1980 in 8 patients who'd received multiple transfusions after surgery. So looking at that overall, it's right, I think, to understand, as the inquiry has seen elsewhere, that screening for hepatitis B surface antigen did not eliminate entirely the transmission of hepatitis B.
Yes. That would be right. The early tests, of course, were relatively insensitive, especially the first one that was used. There was quite a big leap in sensitivity with the RPHA test, and then a further improvement, although I'm not with the RIA test, I don't think in practice there were many, if any, detected. I don't think we detected any donors who would not have been detected by the RPHA, but I'm not completely sure of that.
Can you assist us with understanding why the RIA, the improved sensitivity test, was not introduced until sometime in 1982? Why not earlier?
As I mentioned earlier about the facility, it was a very, very cramped very small laboratory that was in use, and it would have been totally unsuitable for the use of radioisotopes. So I don't know whether it was seriously considered by my predecessor. I obviously I was keen to introduce it, and the link with PFC gave us the opportunity to really, they provided us with a bit of leverage in order to get it up and running reasonably quickly.
Can I turn to non-A, non-B hepatitis? So we can take that down, thank you. When you took up your post as deputy director in 1978 and then as director in 1980, doing the best you can, what was your understanding of non-A, non-B hepatitis at that time?
I was certainly well aware of it when I took up the post in '78, just from reading and reading the literature. I had read about particularly the TTV study in the United States. And in many ways, I thought it was, I looked upon it for many years throughout the 80s as the biggest single issue or biggest problem left for blood transfusion services to solve. Obviously that changed with HIV, but I was very interested in it and followed the literature very closely.
Now you've referred in your statement to there having been a dearth of good quality research in the UK as to the extent of non-A, non-B hepatitis in the UK. But, what was your understanding of the potential seriousness of non-A, non-B hepatitis in 1978, 1980? Did you understand it could have serious long-term consequences?
As far as I recall, the TTV study is the one I keep would keep coming back to because it was I felt it was the most important study. As far as I recall it, the follow-up, I think there were interim reports from time to time during that study, and I think, as I recall it, they were beginning to show some evidence of chronic liver disease appearing. Initially it looked like it was mostly mild chronic persistent hepatitis, but as I recall it was beginning to, those studies were beginning to show some evidence of more serious chronic liver disease.
Do you recall whether you read or were aware of the work being undertaken by Professor Preston and others in Sheffield, which looked at the position in relation to a number of haemophilia patients?
Yes, I was very aware of that when it appeared, when it was published, when that work was published, yeah. Obviously, I didn't have any. Obviously, I didn't provide any information about the real risk in the UK because it would have been reflected the use of possibly imported products.
If we just go to your statement, WITN 0892001, and go to page 67, please. If we look at the second main paragraph on this page, and pick it up at the end of the second line, you say, in the third line, there was an educational issue among some clinicians about the importance of reporting, and in some cases even about the existence of non-A, non-B hepatitis. Hospital blood bank and haematology staff were well aware of this, but not necessarily other users of blood and blood components. Every opportunity was taken to educate clinical staff about this, and also through publications. Now, I'm going to come on shortly to the question of reporting and the publication, I think that's referred to there. But the educational issue among some clinicians, even about the existence of non-A, non-B hepatitis, can you recall, or can you tell us more about what the basis is for that statement?
Just comments at meetings. I can recall speaking to groups, including senior clinicians, some of whom seem to assume that the problem of post-transfusion hepatitis had gone, and seemed slightly, in some cases, a little bit skeptical about whether this was really an issue. Excuse me, that this was really an issue for clinical practice at all. I do recall that in some cases.
I'm going to ask you to look next at a document which set out the process for investigating transfusion-associated hepatitis. It's WITN 0892004. It's a document authored by Dr. Barucha, November 1983, and it's described as a summary of present practices with respect to recognition and investigation of transfusion-associated hepatitis in Northern Ireland. And then under the heading Recognition of TAH, jaundice in a patient who has previously received blood and/or blood products is reported to the Nbts either by the clinical staff or the hospital laboratory. District hospitals are actively encouraged to report all cases of TAH/transaminitis. However, we recognise that a significant number of patients with milder clinical attacks as seen by the general practitioner. Reports from GPs are seldom received. And then the investigation process is then set out so it's a summary of PID, blood products transfused, together with dates, serial numbers of units and reason for transfusion. Clinical and laboratory data on patient are obtained. B, clinical staff in charge of patient are advised to send serum to the PHL for hepatitis A and B markers, EBV and CMV. C, since November 1982, donor serum samples are stored at -20 degrees centigrade in the NIBTS for a period of 1 year. Tests for anti-HBC and ALT are performed on the implicated stored samples. So just pausing there, it would appear that the decision to store serum samples was, at the date of this document, a relatively recent one, November 1982. What had led you to decide to start storing serum samples from donors, and why for only a year?
Well, actually, it says a year. I'm not sure when this was, document was written, but in fact, we ended up maintaining store samples for much longer than that. Many years. I mean, as far as I recall, we were still storing samples 7, 8 years down the line. In fact, the main problem then we encountered was finding that in some cases the oldest ones were no longer in proper condition, dried out, and would no longer have been suitable for testing, unfortunately. But no, we definitely held sample. It may be that in the first instance when we decided to do this, that it was only going to be for a year, but it was much longer than that.
And what was it that had prompted you to decide to start the practice of storage?
Yeah. I can't remember exactly. I do remember it being discussed in Scotland at one of their meetings and being impressed and that by the reasons, well, obviously one of the reasons is set out here for the investigation of post-transfusion hepatitis to help you do that. Also, if new tests came along to go back at the old and look at the old, repeat the samples done by the old test. There were a number of potential advantages. Yes, I think very quickly, I think Edinburgh started to do this around the same time, or if not before. And I was very impressed by the potential benefits of doing this.
And so we can see from subparagraph C, tests for anti-HBC and ALT would be performed on the stored sample. And then D tells us that the next time the donor comes, a sample is taken, and in addition to routine HBsAg, tests for anti-HBC and anti-HBs are performed on the sample obtained on this occasion. And E, the unit of blood collected from such a donor is not issued for transfusion until all the tests are completed. What was the thinking behind the tests for anti-HBC and ALT? Was that on the basis that they may be an indication of non-A, non-B hepatitis?
Either non-A, non-B or B, indeed, hepatitis B, testing for anti-core might have been an indication of a very low level of hepatitis B that was missed by the existing screening test, and the anti-HBs would be done with that, alongside that, to interpret the result. ALT again could be non-A, non-B or hepatitis B possibly, particularly non-A, non-B.
And then if we go to the bottom of the page, under the heading 3, action taken, it says, if ALT levels in the donor are repeatedly within the normal range and no hepatitis B markers are detected, the donor is retained on the panel and treated as normal. Just pausing there, what was the reference to repeatedly within the normal range? How many tests would be regarded as being repeatedly within the normal range? Is that a reference to testing the stored sample
really,
and then?
I really can't remember how many times we would have repeated the test. It would probably be influenced, dealt with, I imagine, on an individual basis. For example, depending on how strongly the implication was. Many of these cases, where there were either the recipient, it may have been rather dubious as to whether it really was transfusion hepatitis, or where multiple donors were involved, perhaps, so a very large number of donors were involved. That might influence the decision about reinstating the donor. In other words, a judgment would be made on the basis of various factors, not just a fixed number of, as noted there.
And then, just to complete it, B says, if an implicated donor is noted to have repeated elevation of ALT in the absence of hepatitis B markers, his/her GP is notified for further follow-up. Blood and or blood products from such donors are not used for transfusion. So that was the procedure at the Northern Ireland Blood Transfusion Service. If a possible case of transfusion-associated hepatitis was notified to you, would you be notifying the PFC or SNBTS in relation to that, if the donation was potentially or if the implicated donor was someone whose donations had been used as part of the process of sending plasma for fractionation?
I really can't remember what the policy was. There probably was a PFC policy on that issue, but I really can't remember at what point one would, the PFC would have liked to be informed. I imagine there would have been a policy on that.
And then can I just ask you to look at two further documents on this issue? The first is a letter from you to Dr. Gunson, NHBT 00945549_007. So we can see it's dated the 30th of May 1984, and you are reporting cases of transfusion-associated hepatitis to Dr. Gunson. You say, I enclose summaries of the only 3 convincing cases of post-transfusion hepatitis which were reported to us during 1983, 1 hepatitis B and 2 non-A non-Bs. I apologise that due to an oversight there's been such a long delay in sending you these reports. I should perhaps add that the number of reports in 1984 so far has increased strikingly. This followed some publicity which we initiated regarding the need for reporting of such cases to the Transfusion Centre, and tends to emphasise the degree of underreporting which has existed. Can you recall, Dr. McClelland, whether that upward trajectory in reports, whether that continued? Did you continue to receive a greater number of cases?
I suspect perhaps not. I know my colleague, Dr. Barucha, did publish a report again, just in the Ulster Medical Journal, on the non-A, non-B in Northern Ireland. I don't think that showed very many cases at all. So I am not sure, but I suspect not. I don't think there was actually even as big an increase as I seem to be anticipating here.
Well, if we just look at Dr. Baruch's 1985 article, so it was accepted for publication in 1985, published in 1986, WITN 0892005. So post-transfusion hepatitis, a problem in Northern Ireland, ? And you'll see, Dr. McClelland, it says, accepted 8th of October 1985, summary, a retrospective analysis of post-transfusion hepatitis reported to us from 1980 through 1984 revealed 16 patients. We believe that this apparently low incidence is due to lack of notification and make a case for direct notification to us of any suspected cases. Disqualification of implicated blood donors is of prime importance in prevention of transfusion-associated hepatitis. And then if we go to, well, perhaps we pick it up at the bottom of page 3. So in that last paragraph, it says, in this report, 11 of 16 patients developed post-transfusion hepatitis, which was due to causes other than hepatitis B. If a diagnosis of non-A, non-B hepatitis is suspected, it is important to identify the donors implicated in order to prevent further transmission to other patients through future blood donations. In the absence of a screening test, our present policy is empirical exclusion of any donor implicated in 2 instances of post-transfusion hepatitis. Can you just help us in understanding what that refers to, what that means? The empirical exclusion of any donor implicated in 2 instances of post-transfusion hepatitis?
I think that would have just referred to the scenario where the same donor was implicated into cases of post-transfusion hepatitis. I suppose the other possibility would be if some of the tests on the donor that you referred to earlier were positive, but I think this probably refers to being implicated on 2 occasions.
And on that reading, it would mean that if there was a donor implicated in 2 occasions, then irrespective of the testing on those donor samples, they would be excluded.
Possibly yes, although I'm not. I don't recall exactly. I mean, this is a scenario that would, in practice, as far as I remember, rarely ever occurred. If it ever occurred, but I would say it was a very rare situation.
If we just go over the page, it's going to draw attention to the last 2 paragraphs, which may be of wider importance. So the reported incidence of post-transfusion hepatitis shows great variation, the lowest being 2%. There is little doubt that the apparently negligible incidence in Northern Ireland during the years 1980 to 83 must be due to lack of notification. It is still uncertain how many cases are missed, and even among a small population like that of Northern Ireland, it's difficult to hazard a guess at the true incidence of the disease. Of the non-B infections, non-A, non-B hepatitis is a significant problem, particularly in terms of chronic liver damage, despite the mildness of the initial illness. In the absence of tests capable of detecting an infective donor, we must rely on notification of transfusion-acquired infection and retrospective investigation of blood donors for eventual disqualification of implicated donors. Lack of notification may be attributed to several factors. A significant proportion of non-A, non-B infection is subclinical, and serum transaminase levels fluctuate independently of clinical illness. Vague symptoms after surgery or anaesthetic may be ignored by the patient and doctor. The prolonged incubation time of hepatitis B and moderate incubation time of non-A, non-B infection sometimes make the correlation between transfusion and clinical illness difficult. Patients are discharged from hospital, and the present system of liaison between general practitioners, hospital doctor, and the NI blood transfusion service is unsatisfactory. There is a good case for direct notification to the Northern Ireland Blood Transfusion Service of any cases of suspected transfusion-associated infection. Do you agree with everything that Dr. Barucha and her colleague wrote there?
Yes, I would have agreed at the time. Yes, indeed. I suppose as things turned out, when we came to do hepatitis screening, it did actually turn out that our incidence of hepatitis C among donors was particularly low, but I don't think that changes the fact that, yes, I would agree with this, and I particularly agree with the message that is being, to some extent, there's speculation here about suggesting that the reason must be due to non-notification, but I very much agree with the message which is being sent out to encourage doctors to look out for this condition, and she's even saying report it direct to the blood transfusion service.
Now, I'm going to turn now to ask you some more general questions about the donor collection sessions and donor selection. And you've told us, I think, in your statement, and we've seen elsewhere, that there were donor collection sessions in a range of different venues. as well as in some fixed locations. In terms of the staffing arrangements at the donor sessions, you have mentioned in your witness statement that there would be a doctor overseeing the blood donation sessions who would receive appropriate training. What particular kind of training relevant to the donation collection exercise would the doctor have received?
Going back to when I started with blood transfusion service, we had one full-time associate specialist who looked after various aspects of the donor program, including the rotation of, making out the rota for doctors and liaising with session doctors as well. And certainly when a new doctor started, would have gone out with this doctor who's an associate specialist and undergoing training on all the aspects with respect to the procedures and particularly the selection procedures. As well as that, we did have regular update meetings for all doctors. About twice a year, I think, on Saturday morning, we had to get together and talk through all the sort of relevant issues at the time and updated them with any changes.
And then the donor attendants, did they have any particular qualification or experience?
They didn't have any particular qualification. They underwent training again. They were overseen when I started with one head nurse who was a sort of sister level nurse, to use the old grading parlance, and she would have been responsible for organising the training of all donor attendants and assessing them with respect to the roles that they were able to take on. Some of the more senior and experienced ones and who were deemed to have passed the sort of training assessment would have been permitted to carry out the interviews with donors, which when the routine oral interview, which we had in place.
Now, in the kind of community settings that you've described for some of the collections, village halls and the like, or indeed in the workplace sessions, were there opportunities or facilities for donors to talk in confidence to either the donor attendant or the medical officer?
Well, this could be quite variable. Indeed, there was a curtained off area in which these routine interviews took place, and also in which if there was an issue for the medical officer, that would take place in that same curtained off area. But inevitably, depending on the venue, that could have been that was a bit problematic at times. I'm sure confidentiality couldn't always be completely assured.
And in terms of the workplace sessions, which you've explained were very important for the Northern Ireland service in order to be able to keep up with the level of donation it required, did you ever consider whether employees giving donations in workplaces were truly voluntary, or whether there might be an expectation from their employer that if a session's been arranged, they would go along and donate?
I can't remember that being a very strong consideration when I started off, or even for some time. I guess it might have crossed one's mind a little bit with HIV when you started to think about whole categories of donors as opposed to individual donors. But no, I think without workplace sessions in those days, even with all the closures and so on, we would still have felt we were very dependent on those sessions.
You've said in your statement that you think that you use the national guidelines for the selection examination of donors. Could we just have a look at those? PRSE 0004358. If we just zoom in on the top part of the page. So NBTS, Memorandum on the Selection, Medical Examination and Care of Blood Donors. This is a version from December 1977, Dr. McClelland. There are various versions of this document at different dates. Do you think it's likely that this is the guidance that you used?
Yes, we did use these national guidance. Yes, certainly when I started. I think they were I can't remember exactly when, mid to late 80s. I think we started producing our own questionnaires, and I think we produced our own sort of alphabetic guidelines for selection of donors as well, to put them into sort of local context. But yes, we would have been basically following these national guidelines.
And if we just look briefly at the bottom of the page, we can see under the heading Medical History, a donor is the best judge of whether he is in normal health, and truthful answers to simple questions concerning his medical history and general health form a main part of the examination. In practice, the donor session clerk should specifically question the donor about the conditions listed on form Nbts 110A and request the donor's signature on form Nbts 110. And then if we go over the page, we can see at the top of the page it said that there are 3 categories of illnesses or conditions listed in the form: those which disqualify a person from acting as a donor, those which require referring to the medical officer for decision as to acceptance, deferral or rejection, those which necessitate temporary deferment, e.g. pregnancy, contact with infectious disease, inoculations. You've described in your statement how the donor attendant would undertake a health screening interview. Is that essentially the process we see described here?
I'm not absolutely sure whether it's quite equivalent. It sounds what we would have. Obviously, when the donor arrives, they are greeted by a clerical officer who would go over certain basic details, such as, when did you last give blood, or a few basic details. I'm describing our practice, and then at the next stage would have gone through a more detailed interview with the donor attendant. This seems to imply that the interview is conducted by the clerical officer, but I'm not sure. Maybe that may not be the case.
If we just go then to the bottom of the next page, we have the heading at the bottom of the page, jaundice or hepatitis. Individuals who give a history of jaundice or hepatitis or in whose blood anti-HBsAg is present may be accepted as donors, providing that they've not suffered from jaundice or hepatitis in the previous 12 months, have not been in house contact with hepatitis or received a transfusion of blood or blood products in the previous 6 months, and providing their blood gives a negative reaction for the presence of HBsAg when tested by a sensitive method, RPH or RIA. Now, Dr. McClelland, as currently understood by the inquiry, this recommendation or this suggestion that individuals who give a history of jaundice or hepatitis may be accepted as donors, provided they've not suffered from it in the previous 12 months, was a change introduced in around 1977, following the report of an advisory group. But it was left open to regional transfusion centres as to whether they adopted that or whether they continued with the previous practice of permanent exclusion of donors with a history of jaundice or hepatitis. What was the policy in the Northern Ireland blood transfusion service?
I am struggling to remember exactly how we dealt with this area of history of jaundice, I'm afraid, and unfortunately there is no documentation available. I know when I retired there was a lot of guidelines and documents that would indicate what the exact policy at particular points in time. I haven't so far been provided with anything that really indicates what our policy was. I mean, obviously there are three possibilities: follow this and only accept people who are accept anyone who hasn't had jaundice in the last 12 months, or take the more rigorous view that we can't exclude the possibility this was not A, non-B hepatitis totally, in which case maybe only accept people who have the jaundice in childhood. I have a feeling, but I can't totally, I have no, I remember this was a frequent issue of discussion at our medical officer meetings. I have a feeling, although I have nothing to back it up, that it was a kind of halfway house in that it was left, this would have been, I know, sorry, I shouldn't, I do know that our questionnaire, that when we introduced these questionnaires, it did ask the question, have you ever had jaundice or hepatitis? And that was asked along with things like, have you ever had brucellosis? Have you ever had cancer? In other words, it's asked along with issues or items that would result in permanent deferral. I have a feeling, though, so we were picking up people who had a history of jaundice at any time. They would be referred to the medical officer, I think. I have a feeling that it was a kind of assessed on an individual basis, possibly based on obtaining a GP letter. The vast majority of these cases we knew would have been caused by hepatitis A, infective hepatitis. It may be that I think if the doctor was content that this was a typical case of infective hepatitis, perhaps as part of a local outbreak or something like that, you could be virtually certain that it was hepatitis A. But I can't be completely sure. Say the only little bit of evidence I can look at is that questionnaire which asks, have you ever had jaundice or hepatitis?
You said in your witness statement that your donor selection criteria were very strict, and you recalled several doctors outside Nbts expressing the view that the rules seemed unnecessarily strict. Can you recall anything further about that? What was it that led to that expression of opinion?
I think it was just, it would have been most commonly the occasional comment from GPs who were, sometimes donors would go to their GP and be told they were fit to give blood irrespective of the particular condition they were getting advice on. And the GPs would perhaps sometimes approach us with, what is the logic for excluding a donor with this purpose? It didn't seem to them very logical. I'm really just making the point that, generally speaking, the guidelines took the line that if in doubt, well, even if there was a theoretical doubt about a risk, that you err on the side of safety. I must confess the jaundice hepatitis one perhaps doesn't fully abide by that approach.
Now, I want to ask you next about three categories of potentially high-risk donors. The first are inmates of prisons or young offender institutions. We saw when we looked at one of the annual reports this morning a reference to a session being established at a young offender institution, and you've told us that sessions were held at HMP Belfast and HMP McGilligan. And indeed, I think you've exhibited to your statement some sample donor forms from sessions in the latter institution. So that was a practice you inherited. Did you, your statement suggests that it ended in October 1983. Why did you not end the practice of prison collection earlier than that?
I would say I simply hadn't really considered it seriously up until that point. I was, when I joined the service, I almost got the impression that it was seen as a positive thing. And I remember in one of my placements visiting or being brought to a session that was actually a prison session, and they shown to me with almost a certain amount of pride that this was a very good thing. So I think the short answer is I hadn't really seriously considered it until I began to, well, certainly I think I would have been aware even on our own, well, not on our own, sorry, I was mixing us up with military sessions. No, in our case, the numbers were so small that I was going to say hepatitis B incidence was higher, which apparently was the case nationally. I say in our case, the numbers were so tiny that I don't know if we ever found hepatitis B positive in my time. But sorry, I'm losing my train of thought. Sorry, what was could you repeat the question?
Yes, it was why you didn't bring it to an end as a practice earlier.
Yeah. I simply I began to get information that there were the higher incidence of hepatitis B was a cause for concern. The onset of AIDS was clearly an influencing factor, because for the first time you started to, or at least in my case, the first time you started to think in terms of whole groups of donors, not just individual donors being assessed on an individual basis, but whole groups who might have statistically had an increased risk. So when and I remember communication with Dr. Gunson, who gave us the figures. I don't remember meetings I had being told that this, it being discussed very much. Then I heard about the medicines inspector review on some sessions, and that was certainly quite an influencing factor. And when that information comes through, I decided to stop it forthwith.
Looking back now, and having regard not only to the fact that prisoners might be regarded as being a higher risk group, but also the fact that they may be less well placed to give candid answers to questions, maybe less truly voluntary as donors. Do you think that prison donations should have stopped long before October 1983?
I think there is an argument for that. Yes, I think there is an argument that they should have.
Now, the second category I wanted to ask you about, which you mentioned a moment ago, is military donation sources. What role did collections from military sources play in the work of Nbts?
I think it was quite a significant contribution, especially in the 70s, continuing in the 80s. I think the numbers were becoming less and less. There were still some army sessions into the 90s, certainly, but the numbers have become very small. But certainly in the 70s, when, of course, there was such a large army presence in Northern Ireland, yes, there were quite a significant contribution, quite a lot of sessions.
And was consideration given ever, to your recollection, to the possibility again that those serving in the military might not be truly voluntary donors, or might, if they have engaged in higher risk activities, be in difficulty in being truthful about that in donor sessions?
Perhaps I was aware, certainly it was our experience, that there was a higher incidence of hepatitis B among army donors. Certainly, that was the case. I can't remember how much consideration I would have. I think certainly during the 70s and even into the 80s, I would almost say we can never say totally dependent on these donors, but they were a valuable source of donors at a time when we were struggling at times to maintain the blood supplies. So I think that would have been a big factor.
And then the third category I wanted to ask you about is those who have used drugs, intravenous drugs. Now, but this is before we get to the AIDS leaflet, which is the next topic I'm going to ask you about. How were donor attendants or medical officers at donor sessions expected to evaluate whether somebody might have a history of drug use, other than the obvious that if they rolled up their sleeve and there were needle track marks, you might see them if it was the correct arm. But other than that, what steps were taken to try and reduce the chances of using donations from drug users?
Other than the questions that would have been in the questionnaires, I think it would have been based on the interview and the general assessment. I can't remember that there have been very much specific beyond that asked of donors that might have uncovered that kind of thing. Obviously, in Northern Ireland, we had a particularly low incidence of intravenous drug use, very, 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 very low, and it was probably directly related to the Troubles. In fact, the actual control exercised by paramilitaries. hard to think of an advantage of paramilitaries, but it looked as if that was always my information from public health doctors that there was a very low incidence of intravenous drug use in Northern Ireland during that period, and it was probably related to the Troubles, actually.
Now, I'm going to ask you next about AIDS and the response to AIDS from the transfusion services perspective. If we go to your witness statement again, Dr. McClelland, WITN 0892001. And if we go to page 63, please. So at the bottom of the page, you say this: my earliest recollection of HTLV3/AIDS was of reading reports from the US about AIDS being associated with haemophilia. I believe these reports were in MMWR bulletins, 1981/82. I also recall an AABB meeting, that's the American Association of Blood Banks, I think, in or about 1982, I think, at which AIDS and its possible relevance to blood transfusion was discussed on the fringes of the meeting. Subsequent to this, I would have been aware of reports appearing in the scientific literature which provided increasingly convincing evidence of a single infective agent, including the first report of a child in which the only risk factor appeared to be blood transfusion. Do we understand from this, Dr. McClelland, that you yourself read the MMWR bulletins?
Yes. I can't. I think it may have come via the CDSC, or it may have come direct. I can't recall exactly, but I remember I think it was a weekly bulletin. Yeah, and yes, there was. I'm not sure how long I continued to have it, but yes, I remember reading a lot of information on AIDS in that.
And you referred there to the first report of a child in which the only risk factor appeared to be blood transfusion. That is, I think, probably a reference to the child, the Californian child. We refer to it from time to time as the San Francisco baby case, reported in, I think, the MMWRs in December 1982. So would it be right to understand that as a result of what you read as set out here, by the end of 82, beginning of 83, was it your understanding that the likely cause of AIDS was an infective agent, as you describe here, that could be transmitted in blood or blood products?
Yes, I think that's right. That did seem at that point to be the most likely cause, an infective agent.
Now, I'll ask you in a moment about the AIDS leaflet and its introduction and use in the service. Before I do that, do you recall whether Dr. Main or the Eastern Health and Social Services Board or the Northern Ireland Department of Health or anyone asked you if you could increase the production of cryoprecipitate so that people with haemophilia could be treated, at least on an interim basis, with a product that was safer in terms of potential AIDS transmission than factor concentrates? Did anyone ever ask you to do that?
No, I don't remember anyone asking me to do that. No, I don't.
And if we go back to your witness statement, Dr. McClelland, WITN 0892001, page 41. At bottom half of the page, So at the subparagraph E, you were asked how quickly the NIBTS could have increased its manufacture of cryoprecipitate had it wished to during the early 1980s. And you say this: as I recall, in the early 1980s, NIBTS could have readily returned production to what it had been in the late 1970s, around 10,000 packs per annum. I believe there would have been the capacity to increase this substantially to, say, 20,000 packs per annum at a guess. Some additional equipment and staffing would have been required, but this had already been acquired in order to produce the large increases in fresh frozen plasma going to PFC. So had you been asked, it looks as though it wouldn't have been a problem for you to increase fairly substantially the production of cryoprecipitate.
Yes, I think it would have been possible. Yes. Although I mean, this is my belief. I think at the time, looking back, that it would have been possible if there had been a clear demand and a clear policy emerged that we should reprioritize our production in that way.
And I asked you a few minutes ago if you were ever asked by Dr. Main or anyone else to do so. Can I put it the other way around? Did you ever raise it as a possible course of action with Dr. Main or anybody else?
No, I don't think so. Specifically, I can't remember. Dr. Main and I would have discussed various aspects of factor VIII and cryoprecipitate and so on. I don't remember any clear steer that there would be that this was the appropriate approach at that time.
Now,
sorry, and I don't recall saying or suggesting to her that we should do that either.
We can take that down, thank you. Now, the leaflets that were then produced in relation to AIDS and blood donation, we start by just having a quick look at BPLL 0007247. This, Dr. McClelland, is the leaflet that was produced in England and Wales with the involvement of the Department of Health and issued at the beginning of September 1983. I'm not going to go through the details of its content with you, but as far as you can recall, was this the leaflet that went into circulation in the Northern Ireland Blood Transfusion Service?
Yes, it was.
Now, we know from other witnesses, most recently the other Dr. McClelland in Edinburgh, who gave evidence last week, that some other centres introduced their own form of leaflet earlier than this, rather than waiting for the Department of Health. Did you give any consideration, as far as you can recall, to producing your own leaflet?
I don't think we did seriously. I would have been aware and was aware that this national leaflet was in the pipeline. I would have considered, in our context in Northern Ireland, assessing the likely risk that it would be appropriate to follow the national line. As I say, all the indications that we had would have been that the risk was likely to be low based on incidence of incidence of any. I don't know if there were any cases of AIDS in Northern Ireland at this point. There might have been one or two that were kind of imported. I don't. I think looking at risk activity. We've already mentioned drug abuse, or intravenous drug abuse, which was very low at a very low level. So what evidence we had incidence of hepatitis B as well. So what evidence we had indicated that we were likely to be one of the most low risk regions. Not one of, I can imagine if we'd been in the situation of perhaps London or Edinburgh, I'm sure ourselves, BTS and the Department of Health and so on might well have considered that we should look at measures to additional measures that we should take. But given the situation at that time, I don't think we did think it would be, we thought it would be appropriate to follow the national approach.
If we then look at PRSE 0002617, you'll see this is an SNBTS directors meeting, 13th of September 1983, at which you were present. If we go to page 3, sorry, let me just pick it up at the bottom of page 2 so you can see the context in the minutes. So the bottom of page 2 has the heading AIDS. It was noted that since the last meeting, the UK leaflet, that's the document I just showed you, had been produced, and the Ministers of Health having made statements on the matter, the leaflets were being distributed. The method of distribution had been left to the directors, who reported as follows. And then we can go to the next page. 4 paragraphs down, there's the heading underlined Northern Ireland. Dr. McClelland had not yet received the leaflets, but would make them available at donor sessions once he did. Do you know why there'd been, it appears, a delay in those leaflets being sent to Northern Ireland?
I don't recall. I would be pretty sure that they would have arrived soon after this date, but no, I can't really say for sure.
And then if we go to DHSC 0101652_002, this tells us about how leaflets were used at the Northern Ireland Centre. So this is a letter from you to Dr. Smithers at the Department of Health in London, 25th of January 1985. Thank you for your letter on the subject of prevention of transmission of AIDS through blood donation. In Northern Ireland, the following approach has been adopted. Until recently, we relied on the display of AIDS leaflets on all sessions. From about 6 weeks ago, we have been handing a leaflet to each individual donor. The drawbacks which have been noticed are firstly that donors often have insufficient time in practice to read the leaflet properly before donating. Secondly, a few individuals have shown resentment at being handed the leaflet. A potential problem is, of course, the difficulty for any donor to exclude themselves at a donor session, but perhaps not surprisingly, it is one we have not been made aware of. I am sure it is desirable to send an AIDS leaflet to each donor with the call-up letter. At present, this is not possible since we used postcards to call donors and have not the clerical capacity to send enclosed leaflets. During the coming year, this will change with the advent of a computerised donor call-up system combined with the use of an automatic enveloper. The problem of informing donors who are not called individually will of course remain, i.e. those who donate at their place of work. We're now supplying local organisers at such sessions with AIDS leaflets. I hope this information is of some help, and I look forward to receiving the updated AIDS leaflet. So it would appear from that, Dr. McClelland, that from the introduction of the leaflet in or around September 1983 to about 6 weeks before this letter, so sometime perhaps in the first half of December 1984, the leaflets were simply being left or displayed at the sessions. Is that correct?
I think, yes, I think so. I think that's what this letter would, that would be my recollection as well, yes.
And so that would really depend upon the donor picking up the leaflet and reading it, would it not? It runs the risk that a lot of donors might not become aware of the contents of the leaflet.
Yes, yes, that's right. Yeah, it's yeah, and this would have been this approach. I mean, I think we would have sent the leaflet out if we'd had the capacity to do it at the outset. But there were. I think we had, and our donor admin and recruitment staff did have real concerns about the impact or potential impact this on donor attendances, and in a society like Northern Ireland, quite a conservative society, I think we had reason to have those concerns. So I probably felt that there may be some merit in this sort of gradual approach to introducing this leaflet, which was something very different to anything that had come before. Yes, it had its drawbacks in terms of effectiveness, but we did introduce the mailing as soon as we were able to. It might seem a sort of trivial problem. The problem of including something in an envelope. You must regard every day the staff would be sending out maybe, what I guess, anywhere between 500 and 1,000 postcards. So it really would have been quite a clerical task to take this on at that point.
I think it's right that it was only in 1982 that homosexuality ceased to be illegal in Northern Ireland.
Right.
And so the chances of, or that would that might mean that potential donors might be even more reluctant than they might otherwise be to, as it were, admit to being in a high-risk category that until very recently had been potentially exposing them to criminal prosecution. Did you ever consider whether there was any other way in which this kind of information could be disseminated to potential donors in advance of the receipt of the automatic enveloper and the establishment of the computerised call-up system? Was thought given to there being some form of public health campaign or display of posters or anything along those lines in that period from the autumn of 1983 to 1985?
I think there may have been some public information on this. I don't know if there was an actual specific targeted campaign with direct relevance to blood donation. But I think the message may have been included with the general campaign about AIDS. That would have been general messaging about AIDS that would have included that message not to give blood in people in high-risk groups. But I can't remember the details.
What about amending the questionnaire? Now, I know you did that slightly later on, but did you consider in September 1983 or thereafter at least taking the step of amending the questionnaire to add a question, have you read the AIDS leaflet? Please tick if you have, to at least prompt people to be aware of the leaflet?
Again, I've with regard to a lot of donor information in use at that time, unfortunately, I don't have any documentation to look to consult and to really prompt my memory, so enable me to give reliable answers to questions like that. I think I mentioned that we did introduce for the first time, a questionnaire for donor. I already mentioned the oral interview with the donor attendants. We did, I think, again, I can't remember the date, introduce a questionnaire initially for new donors to complete at the session, and that certainly did include something about have you read the AIDS leaflet. I say that may well be 85, 86, that sort of time before that was introduced. But that's all I can think of in that area.
So I note the time, and I'm going to move on next to the question of anti-HTLV3 screening. So I've probably got about another 45 minutes of questions, or up to 45 minutes of questions myself for Dr. McClelland, and then we obviously need to give call participants the opportunity to suggest questions. We could, entirely a matter for you, whether we in fact break now until the morning or whether we continue now in the knowledge that we'd probably have to sit late in order to accommodate the opportunity for CPs to suggest questions, or we simply go on to the normal time of 4:30. Entirely a matter for you.
Well, let me ask Dr. McClelland what he would like. Dr. McClelland, can you hear me?
Yes. Sir?
There's a choice. Council will have about 45 minutes or so more questions for you. We're going to take a break now anyway for half an hour, so that would start at 4:45 or 4:10. So it'll be after 4:30 by the time she's finished, just after. Okay. But what then happens is that we allow call participants to ask questions or put forward questions to her which arise from having listened to your evidence and read your statement, questions they would like answered, so that she may ask those of you. And that may be, she has to field those questions. That's going to take half an hour, and that would get us into after 5. And then I just can't say how long those questions would be. My sense is that you've probably had enough for today, or you're getting close to it, but this is a matter for you to tell me, not for me to tell you. And so you may prefer, but it's a matter for you, you may prefer to take a break now and come back at 10 o'clock in the morning, in which case I would think we'll be finished by probably, I would have thought no later than 12, but it's certainly going to be just an hour and a half, 2 hours, something like that in the morning. Now, it's up to you. What would you like to do?
Well, I'm happy enough to press on until 5 o'clock, or what? You say either way we're taking a break now.
But either way, we're taking a break now, having a cup of tea or a break, and then there will be another break, as I say, around about 4:30 or so, for questions then to be asked or put to Ms. Richards. That break will be 20 minutes, half an hour, depending on how long it takes for those questions to come in. And then there'll be the asking of those questions. And then that will be it for the day, and that will be it for your oral evidence to us.
Yes.
So you get it over with, if you like, all today, if you're up for it, but you can have a break now if you'd rather.
I'm happy to press on.
Then let's do that. We'll take a break now until, shall we say, 3:45. So
Thanks.
3:45.
Thank you.